The midline is usually defined by two metal pins impacted into the adjacent vertebral bodies and then verified by X-ray inspection. In this way, the surgeon maintains midline control through all steps of the operation. The disc material is removed completely, using rongeurs, a punch, a sharp spoon, and a raspatory. Remnants of the intervertebral disc left on the vertebral bone are removed with a curette or a motor-powered reamer. Once the approach is prepared, the Caspar distractor is applied. In this step, it is important that the two distractor screws are not placed too close to the disc compartment, but rather in the upper and caudal region of the inferior vertebral body. With the self-locking mechanism of the new Caspar distractor, the distractor sleeves can be locked onto the distractor screws. Thus, the parallel distraction can be easily maintained. The parallel distraction of the segment has to be applied with the distraction forceps. Therefore, the distraction forceps is pushed as far as possible to the posterior rim. Now the segment to be treated is distracted to the required height. For an estimation of the required implant size, the dimensions of the vertebral body base plate can be measured on the MRI and compared with the implant dimensions on the color template. To verify the implant size, the trial implant selected according to the estimated dimensions is inserted in the disc compartment, again under X-ray control. To prevent the trial implant from slipping into the posterior soft tissue region and to avoid the risk of damaging the dura or blood vessels, the safety stop must be turned as far as possible towards anterior at this stage. When the trial implant is impacted, the safety stop can be turned back slowly and under X-ray control to insert the implant deeper. Distraction with Caspar is released to stabilize the position of the trial implant. The handle is removed from the trial implant. The trial implant itself is left in the vertebral body segment. The correct positioning of the trial implant is very important for the subsequent steps of the implantation, as the trial implant serves to determine the reaming line for the keel space in the inferior vertebral body. The position of the trial implant ultimately decides the position of the prosthesis. The reamer guide is mounted on the trial implant and arrested by engaging the locking blocks. The groove for the keel is reamed in two steps. The reamer guide ensures that the two reaming approaches merge to a single groove. Care must be taken that the reamer is fully pushed to the stop. Only then will it be ensured that the reaming space is deep enough and the implantation can proceed without too much manipulation. The reamer guide stops the reamer movement towards posterior about 1.5 millimeters before the reamer hits the posterior edge of the trial implant. Now the Caspar and thus the segment is redistracted and the drilling instruments, including the trial implant, are removed. The prosthesis size is selected according to the size of the trial implant. For each of the three implant heights, there is a dedicated distance yoke, which is introduced into the insertion instrument. The depth stop should be set to the minimum penetration depth. The insertion instrument is tightened on the prosthesis by a clockwise turn of the locking sleeve. Under X-ray control, the prosthesis is carefully pushed into the disc compartment. The prosthesis should be positioned in such a way that the center of rotation of the prosthesis coincides as precisely as possible with the biological center of rotation of the vertebral body segment. Any suboptimal seating can be corrected with the revision repositioning instruments. Active C is the intervertebral disc prosthesis for the cervical region.